Welcome to StudyNeuro. In this presentation, we will examine the surgical management of posterior communicating artery aneurysms, with emphasis on operative anatomy, microsurgical clipping techniques, and practical surgical decision-making during treatment. These concepts are clinically important. We will first look at the principles that guide treatment selection, because understanding aneurysm anatomy and its relationship to nearby vessels and cranial nerves is essential before discussing clipping strategies or endovascular options. Operative planning affects outcomes. Next, we will review the key anatomical landmarks commonly encountered during surgery, then discuss how microsurgical clipping is performed while preserving perforators, parent vessels, and surrounding neural structures that may be tightly adherent to the aneurysm dome. Small technical details matter here. The presentation will also cover the role of endovascular therapy, especially in patients with difficult anatomy or high surgical risk, followed by important intraoperative priorities, possible complications, and methods used to confirm aneurysm occlusion after treatment. Verification is critical. For more high-yield neuroscience education and clinical pearls, join the StudyNeuro community on YouTube, Facebook, TikTok, Instagram, and X. Stay tuned for more neuroscience and neurosurgery content.
Posterior communicating artery aneurysms are among the most frequently encountered intracranial aneurysms, and they remain clinically important because rupture can produce devastating subarachnoidhemorrhage with significant neurological injury. Early treatment is critical. The primary goal of management is to secure the aneurysm before rupture or rebleeding occurs while maintaining normal neurological function, particularly within the nearby perforating vessels and cranial nerves that are closely related to the aneurysm neck and dome. Anatomy guides every decision. Successful treatment depends on careful surgical planning and a precise understanding of microsurgical anatomy, since even small injuries to perforators or the oculomotor nerve may lead to major postoperative deficits. Technical precision matters here. Both microsurgical clipping and endovascular therapy play important roles in treatment selection, and the choice often depends on aneurysm morphology, patient condition, and the relationship of the lesion to surrounding vascular structures. Each case is different. The primary aim of treatment in posterior communicating artery aneurysms is complete exclusion of the aneurysm from the circulation, while maintaining normal blood flow through the surrounding arteries and perforating branches that supply deep and highly sensitive brain structures. Preservation is essential. During treatment, the surgeon must carefully protect nearby vessels, such as the posterior communicating artery and the anterior choroidal artery, because injury or unintended occlusion may produce ischemic complications involving the internal capsule, optic pathways, or thalamic regions. Small vascular injuries can be devastating. Attention must also be directed toward the oculomotor nerve, which lies close to many PCoA aneurysms and may already be compressed before surgery, particularly in aneurysms that project posterolaterally toward the nerve. Anatomy determines the strategy. Ultimately, treatment seeks to prevent rebleeding and reduce the risk of permanent neurological deficits while achieving durable aneurysm obliteration with minimal injury to adjacent neural and vascular structures. Long-term durability matters.
Treatment of posterior communicating artery aneurysms can be achieved through either microsurgical clipping or endovascular therapy, and both approaches aim to secure the aneurysm while preserving normal cerebral blood flow and neurological function. The choice is highly individualized. Microsurgical clipping remains a definitive and widely established treatment because it allows direct visualization of the aneurysm neck, adjacent vessels, and nearby cranial nerves, while also permitting decompression of structures that may already be compressed by the aneurysm dome. Direct exposure provides important advantages. Endovascular therapy uses techniques such as coil embolization or stent-assisted procedures to occlude the aneurysm from within the vessel lumen, and this approach may be particularly useful in patients with difficult surgical anatomy or increased operative risk. Patient selection is critical. The final treatment decision depends on aneurysm morphology, the patient's overall clinical condition, and the experience available within the treating institution, since technical expertise strongly influences procedural safety and long-term outcomes. Each case requires careful evaluation. In microsurgical clipping of posterior communicating artery aneurysms, certain anatomical landmarks guide the surgeon inside a very narrow and high-risk corridor around the internal carotid artery and optic apparatus. These landmarks are not optional details, they are essential for orientation. One important reference point is the optico-carotid region, where the optic nerve lies close to the internal carotid artery, and this space often defines how much safe exposure can be achieved before manipulation becomes dangerous, especially when the aneurysm projects toward the optic pathway or the oculomotor nerve. The anterior clinoid process and the falciform edge of the dura are also key structures that help define surgical entry, because they mark the superior limits of carotid exposure and often determine whether additional bone removal or dural opening is required to improve proximal control of the artery. Small changes in this area matter a lot. Medial temporal lobe relaxation and the free edge of the tentorium further shape the working corridor, since brain retraction must be minimal yet sufficient, and any excessive pressure in this region can easily worsen neurological outcome by affecting venous drainage or adjacent cortical structures. Careful balance is required. These landmarks together define the operative pathway, and they allow the surgeon to safely expose the aneurysm while maintaining control over the proximal vessels, which is critical if sudden rupture occurs during dissection. Safety depends on orientation. Patient positioning in posterior communicating artery aneurysm surgery is the first step that shapes everything that follows in the operation. It looks simple. It is not simple. The patient is placed lying on the back, and the head is turned slightly away from the side of the aneurysm, with mild extension to open the skull base corridor while still protecting cervical alignment, and then the head is secured firmly using a radiolucent clamp so that imaging can be performed during the procedure without repositioning. Stability is critical here. This setup is designed to relax the brain by improving venous outflow and reducing intracranial pressure, which creates a safer working space for dissection around the carotid artery and aneurysm complex, while also allowing a direct and efficient surgical corridor to the target lesion. Small adjustments can change exposure significantly. It also allows compatibility with intraoperative angiography, so vessel patency and aneurysm occlusion can be confirmed immediately during surgery, reducing the risk of incomplete clipping or missed residual filling that could lead to later complications. Precision depends on preparation. Surgical exposure in posterior communicating artery aneurysm surgery begins with a standard perional craniotomy, which provides a direct route to the anterior circulation and the carotid aneurysm complex. It is the main entry point. It is reliable. A frontotemporal bone opening is performed, and the sphenoid wing is carefully flattened to widen the operative corridor toward the skull base, while the sylvian fissure is widely dissected to separate frontal and temporal lobes with minimal traction and safer access to deep vessels. Each step improves depth control. The basal cisterns are then opened to release cerebrospinal fluid, which helps brain relaxation and reduces the need for retraction, making it easier to reach the internal carotid artery and posterior communicating artery region with clearer anatomical orientation. This step changes the field quickly. This approach allows early control of the proximal internal carotid artery, which is crucial in case of intraoperative rupture, and it also provides excellent exposure of the ICA-PCoA junction, where most aneurysms arise and where precise dissection is required for safe clipping. Control comes first. Arachnoid dissection is the first real step where the surgeon enters the deep cisternal space around the carotid artery and aneurysm, and it determines how safely the rest of the procedure will proceed. This phase demands patience, no shortcuts. The arachnoid membrane is opened sharply and widely to expose the neurovascular structures beneath, allowing clear identification of the internal carotid artery, the posterior communicating artery, the anterior choroidal artery, along with nearby structures such as the optic nerve and the oculomotor nerve, which all sit in a tightly packed surgical corridor where even small errors can cause major injury. Orientation is everything. A key principle during this stage is to avoid manipulating the aneurysm dome before securing proximal control of the parent artery, because premature handling can trigger rupture and sudden bleeding that quickly obscures the field and increases surgical risk. This rule is strict, always. By respecting this sequence, the surgeon reduces the chance of intraoperative rupture and maintains a controlled environment where dissection can proceed safely around critical vessels and nerves until definitive clipping is possible. Discipline defines safety. The Pterional approach is widely used for posterior communicating artery aneurysms, but it comes with important technical limitations that the surgeon must anticipate before deep dissection begins. Exposure is not complete. That is the issue. The main difficulty lies in limited visualization of deep and posterior regions, especially the space behind the carotid artery, the posterior surface of the internal carotid artery, and the small perforating branches of the posterior communicating artery, which often sit hidden behind the aneurysm dome and adjacent neurovascular structures. Small blind zones matter here. These limitations increase the risk of missing the true aneurysm neck or inadvertently compromising nearby vessels, particularly when the aneurysm projects posteriorly or inferiorly, where access through the standard corridor becomes restricted and more demanding. Errors can happen fast. For this reason, careful microsurgical technique and constant awareness of hidden anatomy are essential, because even slight misjudgment in these deep areas can lead to vascular injury or incomplete aneurysm treatment. Attention must stay high throughout the procedure. The subtemporal approach is an alternative surgical corridor used when posterior communicating artery aneurysms are not ideally suited for the standard Pterional route, especially when the lesion anatomy extends posteriorly or behaves more like a true vessel origin aneurysm. It is not the first choice, but it is important. This approach is considered in true PCoA aneurysms and in lesions that project backward toward the temporal region or extend into the temporal lobe area, where direct access from a lateral inferior angle provides a more natural line of sight to the aneurysm neck and its parent vessels, reducing the need for deep frontal retraction. Orientation improves exposure here. One major advantage is better visualization of the aneurysm from a lateral perspective, which helps the surgeon identify and protect small perforating arteries while achieving a cleaner view of the neck for safe clip placement in a controlled manner. That clarity is valuable. It also allows easier temporary clipping and often provides a more favorable working angle for dissecting around the posterior aspect of the internal carotid artery, especially in complex or posteriorly directed aneurysms where the standard approach becomes restrictive. Access becomes simpler in the right case. Clip application in posterior communicating artery aneurysms is a precise step where anatomy must be clearly understood before any permanent closure is attempted. This is the moment where small mistakes become permanent. No pressure, but high stakes. The surgeon first identifies the key structures around the aneurysm neck, including the proximal neck of the aneurysm itself, the origin of the posterior communicating artery, the anterior choroidal artery, and the small perforating vessels that supply deep brain structures, all of which lie very close together in a tight operative space where visual separation can be difficult. Clarity is essential here. Once these structures are recognized, the clip is applied carefully in a way that excludes the aneurysm from circulation, while still preserving flow through all critical branch vessels, since even slight compromise of perforators or parent arteries can lead to serious neurological injury. Precision guides every movement.
In cases with a fetal-type posterior cerebral circulation, preservation of flow through the posterior communicating artery becomes even more important because it may carry dominant blood supply to the posterior cerebral territory, making vessel patency not optional but mandatory for safe outcome. Anatomy dictates the rule. The final objective is complete and secure aneurysm occlusion while maintaining normal cerebral perfusion through all preserved vessels, achieving a balance between definitive treatment and functional safety in a highly delicate vascular region. That balance is the goal.
Intraoperative management of posterior communicating artery aneurysms is centered on protecting critical neurovascular structures while maintaining control of the parent circulation throughout the procedure. This is a high-risk phase. Precision is everything. The main priority is preservation of nearby structures, such as the anterior choroidal artery, the posterior communicating artery itself, and the oculomotor nerve, all of which lie in close proximity to the aneurysm and can be injured during dissection or clip placement if orientation is lost even for a moment. Anatomy stays tight here. At the same time, the surgeon works to secure both proximal and distal control of the vessel, because having control on both sides of the aneurysm allows safer handling in case of rupture and provides a stable framework for clip application. Control reduces chaos. Several risks must always be anticipated, including sudden aneurysm rupture during dissection, injury to the temporal lobe from retraction, venous bleeding from bridging veins, and occlusion of small perforating arteries that may not be immediately visible but carry major functional importance. Small structures carry big consequences. These complications are minimized through sharp and deliberate arachnoid dissection, adequate cerebrospinal fluid drainage to relax the brain, and gentle brain retraction that avoids unnecessary pressure on fragile cortical and venous structures throughout the exposure. Technique defines safety. Sometimes standard exposure is not enough in posterior communicating artery aneurysm surgery, especially when bony structures limit the surgeon's view of the aneurysm neck and proximal carotid artery. This becomes a problem quickly. Access matters. In these situations, the anterior clinoid process can block direct visualization, and the surgical corridor becomes narrow, making safe control of the aneurysm more difficult, particularly when the neck is hidden behind bone or tight dural folds. Visibility is restricted. To overcome this, additional steps may be required, such as partial removal of the clinoid process or release of the petroclinoid fold, and in selected cases, exposure of the cervical internal carotid artery is also used to gain safer proximal control before intracranial dissection continues. The goal is better access. The benefit of these extended approaches is improved visualization of the aneurysm and more reliable vascular control, which allows the surgeon to proceed with clipping under safer and more stable conditions when standard exposure is not sufficient. Safety improves with exposure. After clip placement in posterior communicating artery aneurysm surgery, the work is not finished, because the final step is to confirm that the aneurysm is completely excluded while normal circulation is preserved in all critical vessels. This stage is essential. No assumptions. The surgeon first checks whether the aneurysm has been fully obliterated and whether blood flow through the internal carotid artery remains open, along with preservation of the posterior communicating artery and anterior choroidal artery, since even small, unnoticed compromise can lead to delayed neurological deficits. Verification is mandatory here. To confirm this, several intraoperative tools are used, including microdoppler to assess flow, indocyanine green angiography for real-time vessel visualization, and intraoperative angiography when a more detailed vascular assessment is required. Each tool adds clarity. These checks ensure that the clip is correctly positioned, the aneurysm is secured, and all important vessels remain patent before closing, reducing the risk of postoperative ischemia or aneurysm recurrence. Confidence comes from confirmation.
Successful treatment of posterior communicating artery aneurysms depends first on understanding the anatomy in detail, because the aneurysm sits next to critical perforators, cranial nerves, and major cerebral vessels that can be injured during exposure or clip placement. Precision matters here. The Pterional approach still remains the standard route for most PCoA aneurysms, although the subtemporal approach may provide better access in selected lesions that project posteriorly and are more difficult to visualize through a conventional corridor. Surgical judgment is essential. Careful microsurgical dissection and reliable intraoperative verification help confirm complete aneurysm occlusion while preserving normal blood flow, especially within the perforators and nearby neural structures that are highly sensitive to ischemic injury. Small errors can have major consequences. Thank you for watching. For more high-yield neuroscience education and clinical pearls, join the StudyNeuro community on YouTube, Facebook, TikTok, Instagram, and X. Like, share, and subscribe for upcoming neurosurgery and neuroscience content. Stay tuned for more.